So it's with gratitude and humbleness and respect that I state that I am a white settler, and we, as many different groups of people, are hosting this session on the unceded and ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, the Squamish, the Tsleil-Waututh Nations, and the Métis Charter Community of the Lower Mainland. And this week, perhaps even more importantly, we acknowledge the lost lives of the 215 children that were found at Kamloops Residential School, and know the sadness that their families have felt and the trauma that that has put on. And it's our job at all times to continue to think about how we can truly make better truth and reconciliation, and do that in the way that we live our lives on this land. So with that, next slide. It gives me great pleasure to introduce Rohit Singla. Now, unusually for province-wide rounds, Rohingla is a third-year MD PhD student in biomedical engineering at UBC, and he is doing his work under the supervision of Drs. Chris Noon and Professor Rob Rowland. He's completed before that a bachelor's in computer engineering and a master's in biomedical engineering. He must like to go to school a lot, both at UBC. But he's taking all of that knowledge and has recently received a Vanier scholarship where he ranked first nationally in the NSERC stream. And he's been working with Chris and Rob trying to look at ways to non-invasively quantify the kidney using innovative ultrasound imaging. So Rohit, it's really wonderful that you were able to join us today along with your supervisors, but look forward to your thoughts, and others, remember to put your questions in the Q&A or the chat box, and we'll get to them at the end. So over to you, Rohit.
Well, thank you very much, Adira. Let me just take the 30 seconds to share my screen, double check everyone can see my screen. I'll assume that's yes. And
that's a yes, yeah.
Wonderful, thank you. Good morning, and thank you everyone for spending your morning with me to hear about some of my work and the work we're doing over in biomedical engineering. I'm happy to be presenting today on my work, non-invasively quantifying the transplanted kidney ultrasound with ultrasound. But really, what I want you to take away from this title is we want to characterize the kidney, and we want to try and push the limits of how we can understand what's going on with the kidney in vivo within the human body, and we'll focus on the transplanted kidney, but by no means is this a transplant-specific issue. This does impact the native kidney. Few disclosures, as Adira mentioned, I am supported by a tri-agency scholarship. Dr. Guan and Dr. Rowling are directors of a company which licenses some technology we will refer to later on in the presentation. There are no other disclosures of relevance. A few learning objectives. I'm going to try and set the scene around the epidemiology of CKD and transplant, particularly talking about the mortality and the need for such non-invasive imaging. We'll discuss ultrasound and its different variants with potential applications to the kidney. And then I'll try and hypothesize or discuss how we might be able to achieve what we call ultrasound to histopathological correlates. That is, what we see on biopsy or the factors we see on biopsy, how can we pull those out more specifically using ultrasound alone? I'll then discuss a prospective study that we're in the works of trying to get underway here, looking at non-invasive fibrosis measurement. Spoiler alert for many of you familiar with, say, FibroScan for the liver, this is akin to that and draws many parallels. This should be no surprise to anyone on this call, but chronic kidney disease impacts 1 in 10 Canadians. Global estimates are quite similar, with up to 16% of adults. That translates to 4 million patients with chronic kidney disease in our country. The primary drivers of this include diabetes mellitus, hypertension, and glomerulonephritis. And about 1% of those individuals will actually proceed to end-stage kidney disease. That estimate brings us to about 35,000 to 40,000 individuals. Now, we know from Go et al.'s seminal work in 2004 that with every subsequent increase in chronic kidney disease staging, we experience a concurrent exponential increase in risk for adverse cardiovascular events, hospitalization, and all-cause mortality. And so particularly here, the numbers on the right-hand side are in comparison for end-stage kidney disease compared to a healthy normal, and we can see a dramatic difference, almost 6 times more likely for all-cause mortality events. These individuals require renal replacement therapy. But we also know that end-stage kidney disease alone, while it might sound like a small problem at the 1% of all those with CKD, it is a growing problem. Looking at the prevalence and both the incidence here, the prevalence alone has doubled in the last 20 years, and the incidence still steadily increases, having experienced about a 50% increase over the same 20 years. When looking at it from a cost perspective for dialysis, one form of renal replacement therapy, this population-based study from Ontario, and published recently in 2019, essentially came up with the conclusion that over 5 years, per patient, we expend over $350,000, and at 10 years, we reach nearly $500,000 per patient in healthcare costs. And so quite the long and expensive therapy. To also contextualize that in the frame of dialysis, we can actually compare it to many cancers. Here, those numbers are looking at the breast, prostate, lung, colorectal, dialysis, and pancreatic cancer. Now, while the incidence is actually comparable to pancreatic cancers and is perhaps an order of magnitude below breast and prostate, when we look at the survival probability on the right, we see that for up until the first 4 years, dialysis mortality actually trends quite closely with colorectal cancer. And then after 4 years, it does significantly worse, particularly in women. And indeed, the 5-year mortality in incident dialysis patients is approximately 50%. That number does vary a bit, but 50% is kind of the number we'll use going forward. And so with this in mind, we'd like to give everyone a kidney transplant. But kidney transplant itself is not yet a cure. I think I'm obliged as a millennial to always mention Selena Gomez, who received a kidney transplant a few years ago due to lupus. But more so, that kidney transplant, while it does give us a boost in our 5-year survival rate from that 50 to 43% to upwards of 83 to 85%, depending on whether we have a living or deceased donor, we still aren't at breaking that threshold of, say, 90 to 95% survival. And we also know that this is quite the scarce resource. Here in BC, every year we perform about 300 kidney transplants per year, leaving 90% of our individuals still on the waiting list. Furthermore, one can imagine that receiving a second transplant, should your initial transplant reach failure or loss, can be quite difficult. There's a number of reasons around that, but we'll keep that in mind that these are precious resources and we want to maintain graft survival as best we can because everyone counts. Now, when we take the long perspective and look back 10 years, 10 to 12 years, and say, how have our outcomes been? Well, our short-term allograft outcomes have actually improved significantly, but the long-term allograft outcomes have not. They've remained steady over the past decade. This is in spite advances in, say, therapeutics and clinical monitoring, and even our understanding of the pathophysiology of transplanted kidneys. And so we have to ask the question, what's driving this? What could be contributing to this issue? To me, one significant portion of this driver is this concept of scarring or fibrosis. Dr. Darren Ewan, when he was here giving a grand rounds about 2 years ago in 2018, they put it quite well in that all paths lead to scarring or fibrosis. Briefly, in the context of irrespective of the primary injury a kidney will face, it undergoes 2 main responses. In the case of the hemodynamic response, we see a compensation in the RAS pathway, leading to pro-inflammatory and pro-fibrotic pathways being activated and contributing to glomerular sclerosis, interstitial fibrosis and tubular atrophy, and in advanced stages, a decrease in size. The non-hemodynamic response also contributes to this by increasing cytokines, increasing cellular recruitment, inducing oxidative stress, and further and foremost, contributing again to glomerular sclerosis and IFTA. In the case of a transplanted kidney, this primary injury or this chronic injury may be the recipient's immune system, it could be the nephrotoxic drugs that they're on, or it could be recurrent underlying disease, that initial reasoning for why they had end-stage kidney disease and reappearing and re-damaging that new transplanted kidney. All that to say is that it results in fibrosis. Largely speaking, fibrosis is irreversible. And so that in itself allows it to be potentially a good biomarker of chronic kidney damage, whereby we can use that as a way to assess disease progression, as well as response to treatment, and understand essentially the quality of the kidney as it stands. We also know that fibrosis has prognostic power. This paper from 2018 looked at the differences based off Banff criteria at biopsy proven fibrosis upon implantation, and we can see that it has quite significant differences in the likelihood of having an event in the coming months. And the differences are start quite early, as less than 10 months, we already see major significant differences between, say, 10% and 50%. But biopsy is the current standard for fibrosis. Is it the best standard? Is it the best we could possibly do? We know it's not EGFR, as EGFR is insensitive, in part due to adaptive hyperfiltration and the compensation there, but also due to confounders in age and muscle mass and others. Biopsy itself comes with significant complication rates. Reported literature says 1.8 to 5.2%. And these can include hemorrhage, arterial venous fistula formation, pseudoaneurysms, and in rare cases, graft loss. But furthermore, biopsy comes with a sampling error. This notion that we are using a few millimeters of tissue to ascertain what is going on in the organ overall and at a whole. We assume it's homogeneous in nature, particularly with fibrosis development, but perhaps it's more likely to be heterogeneous, and that if we have an error in our sampling, we have an error in the status of the kidney. There's literature that says there's also significant inter-observer variation in how individuals or pathologists will interpret slides. I will comment that here in BC, we have 3 renal pathologists who all work very closely together and who are phenomenal colleagues and individuals. And so perhaps this variation is quite limited in BC. But nonetheless, other parts of the world experience this variation. Furthermore, we know that because biopsy is invasive, it's not often that we have the ability to temporally monitor our patients. We can't reorder a biopsy without just cause. Currently in BC, we do not perform protocol or surveillance biopsies for our kidney transplant recipients, although some centers in the world do that. Needless to say, every time we perform biopsy, it incurs an additional cost, as well as unnecessary, perhaps avoidable patient pain. And then one other critique, perhaps, about how we grade fibrosis itself based off biopsy is that it is a semi-quantitative grading system, that Banff grading system, and it treats these categories between 10 and less, 11 to 25, 26 to 50, and then greater to 50 as being somewhat comparable. And to me, the question there from a research perspective is if we can't do better, if we can't have a more granular or finer buckets for our fibrosis. So in my research, I see the unmet need as this, that for adults with a kidney transplant, how can we provide a non-invasive, accurate, reliable, and repeatable measure of kidney fibrosis? That is, how do we get the benefits of a blood test and being able to perform it all the time, but also the power of fibrosis, biopsy for fibrosis, without the unnecessary complications? I believe ultrasound may be the way to go with this. And I say this for a few reasons. Of course, ultrasound has its great benefits in being non-ionizing, so radiation-free, essentially. Non-invasive, we don't have to stick a needle into anyone, and it's real-time. What we see on the screen is essentially what's happening in real time within the body. But perhaps more pertinently and more important for our clinician colleagues on the call is that ultrasound is becoming easier to use and easier to access. We're not seeing manufacturers create as many, perhaps, cart-based systems, but more and more individuals are becoming portable space systems. Here we have the Clarius transducer, where we have a full-featured ultrasound machine that is wireless, smartphone-based, and a fraction, order of magnitude of the cost of a cart-based system. I won't say they're equivalent systems. I will say they're comparable. But what they are is that we now have easier access to ultrasound. And this sort of point of care ultrasound is being considered by individuals across the world, where some curriculums have tried to propose how to integrate POCUS into nephrology training. The evidence around POCUS is beginning to emerge in that it has the potential to diagnose and treat. And so from my perspective, if POCUS is becoming widely available and easier to access, then we should really maximize the power of ultrasound to inform us of the organs within the body as best we can, particularly with the kidney. And so if we review the different forms of ultrasound, the most common one, of course, perhaps everyone is familiar with, is B mode, this grayscale depiction of tissues within the body. And it is fairly useful. It is useful to give us a sense of size and volume. It's useful for echogenicity, that is the brightness of these images, and compare them to, say, reference tissues such as the liver. And currently, it is the first line imaging modality for renal allograft dysfunction in combination with Doppler, which we'll talk about in a second. But can we do better? Some researchers have demonstrated that these size measurements or echogenicity have moderate correlations on the order of 50 to 60% with eGFR and kidney function. It's not very compelling evidence, though. But that said, very recent work from 2019 tried to go above and beyond and say, from an B mode ultrasound image, can we actually predict eGFR? Do we need to perform that biomarker assessment? Now, they did show surprisingly good correlation at about 74, 75%, but they underestimated kidney function by a severe, what I consider a significant amount, at 7, almost 8. And we know that a small change like that could likely result in someone being classified as a different stage of CKD. While I do like the premise of this kind of paper and this idea here, to me, the critique is also then that it doesn't move past eGFR. It still relies on something we know as an insensitive measure and doesn't really propose how we can advance what we know with ultrasound. This paper, recently published as of a few weeks ago, does start to get that idea. Push beyond just eGFR and let's get at the fibrosis itself. In a retrospective study, they looked at a few hundred individuals with all-cause native kidney biopsy, and they claimed their prediction for FDA grade based off these biopsies was about 90%. The figure on the right there is their confusion matrix, so their predictions across the top row, the ground truths down the columns. And for the most part, yeah, I agree, it is a relatively good correlation and good confusion, but we can clearly see that there are some cases where they're predicting class 1 and it's not quite the case, as well as we can see that there's a fair bit of skewed data where they have a lot of class 1s as well. I'll also note that some other issues with this paper were that it's a single pathologist. There was no Banff grading. It was actually purely pathologist interpretation and classification, and that it was a single center study. So we haven't seen any external validation. But moreover, the result of this work doesn't inform us. It really relies on this correlation. It doesn't explain what might be going on in the kidney to be causing this fibrosis. And it doesn't connect the dots between that histology and the ultrasound signal and how they're related. And so despite the good results and accuracy, we're still left wanting to know more. When we move on to Doppler ultrasound imaging, this is of course excellent for patency on flow. and is informative for vascular pathologies such as renal artery stenosis or a thrombosis, the renal artery stenosis being the most common. The absence of flow is actually also quite useful, as it may suggest, say, renal thrombosis on the venous side. And then post-biopsy, it's an excellent means to evaluate for that risk of arteriovenous fistula formation that I talked about earlier. A common index that individuals often like to derive and calculate from the Doppler is this renal resistive index. Essentially, a difference between the systolic velocity, the diastolic velocity, taken as a ratio to the systolic velocity. And what it's meant to do is provide a surrogate measure for what's happening within the kidney's vascular resistance, an intrarenal resistance measure. It can be performed anywhere along the vascular tree, but is commonly performed at the main renal artery. As you progress to smaller and smaller branches of the tree, it becomes more difficult to perform reliably. That said, the literature on renal resistive index is quite mixed. Some groups have demonstrated good correlations with biopsy-proven glomerular sclerosis and fibrosis, while other groups claim that there's no correlation whatsoever. In fact, some individuals will go as far as say that the renal resistive index is not renal specific, but more of a vascular reflection of what's happening in our entire vasculature system. And it's subject to hemodynamic factors, your cardiac output, your heart rates, and numerous other issues that might be impacting how your vasculature is really behaving. So we want to push again closer and closer to the kidney and move away from, say, the vasculature and the organ overall. One variant of ultrasound, called contrast-enhanced ultrasound, does this by the use of injecting a contrast medium, typically microbubbles. We can quantify and essentially monitor how those bubbles traverse through the bloodstream and to the point at which they reach the kidney. This, in essence, allows us to quantify the rate of perfusion, how long it takes for blood to perfuse the kidney, and a few other quantitative parameters from that. This paper from Microcirculation in 2019 tried to use contrast-enhanced ultrasound to differentiate between acute and chronic rejection, which, as I mentioned earlier with the epidemiology, is kind of what we want to get at. We want to start looking at when cases of chronic rejection occur and identifying signals of damage. They found that serum creatinine doesn't really provide a strong, compelling signal. They found that renal resistive index provides no signal difference between the two. But what they found was that they looked at this new index, a combination of age, a change in kidney volume, and the time to peak perfusion in the kidney. And they found that there's a significant difference. A good sign. They found also independently that the time to peak perfusion was significantly longer in chronic rejection than acute rejection. Promising. However, contrast-enhanced ultrasound does require a specialized machine, as well as specific contrast media to be injected. So still not quite exactly as easy as we want it to be, but a promising avenue of research. Perhaps pushing forward and moving from just the vasculature to the actual tissue of the kidney itself is this concept of elastography. There's many variants of elastography. I won't cover them all, the different types, but it is akin to what we see in FibroScan for the liver, where the image we have here is actually a shear wave elastography image of the kidney. The general concept here is to induce shear waves just like we see in the water, into the body. And we want to cause small vibrations into the body to induce a small amount of displacement of these tissues. Then using ultrasound at its real-time nature and high imaging frequencies, we can actually observe the displacement of these tissues as they occur. From that change in displacement, we can calculate the velocity, and with a bit more advanced math, we can determine the actual stiffness of the tissue. The idea here is that the faster a wave travels, the stiffer the tissue is. Now, I've been working on a systematic review of kidney elastography for transplant, particularly looking at fibrosis. And the body of literature, of good quality literature, that accurately has a good sample size, say above 20, reports the appropriate values, and has a reproducible methodology is quite small. We're looking at 15 to 20 papers overall being assessed right now. And the results of those 15 to 20 papers is quite varied. In part, some individuals say that elastography of the kidney has no correlation to any biopsy parameters, such as CICT for fibrosis. Some people found a significant difference, but it's in the early stages, I would say, overall. And what we're finding is that more and more, we need to be accounting for these different confounders in kidney elastography. It's challenging to perform. In particular, kidney elastography or kidney stiffness is subject to blood and urinary pressures, pretty atypical given, say, the liver, which is also highly vascularized, but also quite large and diffuse. The kidney's architecture itself is anisotropic, meaning it's not the same in all directions, and so the orientation of how you observe these displacements does matter. People often also don't account for, say, the potential for other microstructural changes to be happening in their assessments. We also know that body habitus and more recently, even hydration status will impact the kidney stiffness. Many of these confounders are partially included or not included in these previous studies, and the body of literature in understanding these is recently emerging. A brief comment is that the existing technologies for measuring stiffness rely often on a single point or a small region of interest. That may be fine for certain use cases, but really, as pointed out by a review paper from 2020, there's a need for more comprehensive, perhaps volumetric fibrosis imaging. We need to be able to assess the organ as a whole rather than in small portions. That's where technology developed by Dr. Rowling, as co-invented by Dr. Rowling, may benefit. This notion of S-wave, or shear wave, absolute fibroelastography, essentially leverages an external vibration source, seen here in the image on the bottom left, to allow us to acquire volumetric imaging, as well as perform imaging at larger depths that may not be otherwise feasible with other technologies. Some great work in our lab has been done on validating this concept for liver fibrosis, much akin to FibroScan, but also other organs such as breast cancer, the placenta, and prostate cancer. And Dr. Schneider published some work on ex vivo porcine kidneys and how S-wave is blood pressure dependent, essentially. Getting back to that, one of the confounders I mentioned earlier. What remains to be seen, however, is how S-wave may be used in the kidney transplant case in vivo, and when it's subject to the recipient's vasculature, when it's well perfused and undergoing live changes. Nonetheless, a promising technology. So getting back to the unmet need, I've talked about a few different variants of ultrasound and commented that we still need to try and push it further and further to get at what is happening at the microstructural level. The way to do this is in its earlier stages, perhaps in its infancy, but it's in a term we call quantitative ultrasound. Now, quantitative ultrasound broadly means to measure something from ultrasound, but to me it means to really characterize or model an organ in terms of how it impacts the ultrasound wave, the raw wave we send into the body, before we see it depicted on a screen, before we do any processing on it. An early group in the 90s postulated and demonstrated quite nicely that the glomeruli in the kidney is the main scatterer for ultrasound. That is, as an ultrasound wave comes in from our probe, it'll interact with the glomeruli as a scatterer and cause the wave to go into all different directions. Some forward, some off to the side, and some actually backwards, or what we can call backscattering. Using this information, we can actually quantify how much of this scattering signal was in the backwards direction. We can actually measure the scatter diameter as well. There are a few other parameters we can measure, but I want to focus on these two for now because they could actually potentially directly relate to what we see in histology. Glomerular sclerosis, or a denser glomeruli, would likely cause a change in how much is scattered, both in the backwards direction or perhaps in the diameter overall. Glomerular hypertrophy, if we can really push ultrasound to its limits and measure glomeruli using ultrasound, we can perhaps get a sense at the early stages of disease what might be going on at the nephron level. This hypothesis is supported by some early work in the 90s by this one group, as I mentioned. They, at the time, however, used fairly old ultrasound technologies, and as you can imagine, in the last 30 years, the technology has significantly improved. And to me, it warrants revisiting these concepts, revisiting and improving on the variations they reported, and really pushing towards the nephron level interrogation. With that in mind, what I would like to propose is a prospective study as part of my PhD research that does exactly that, that tries to connect ultrasound to the histopathological parameters using all-cause kidney transplant biopsy so that we could perhaps quantify fibrosis non-invasively. Essentially taking a transplant recipient or a patient with a transplant who has to receive a biopsy, using that biopsy to inform our recruitment, and so that then bringing them back in for a controlled research-based ultrasound scan so that we can elicit parameters such as volume, such as stiffness, and such as effective scatter diameter, and look at the correlations with what we see in biopsy. We have multiple hypotheses we can ask here, particularly if we can perform S-wave reliably and demonstrate its limited variability in, say, living donors. Looking at the cortical stiffness, because that is where we take our biopsy measurements from, and how it correlates with IFTA. And then, of course, backscatter and scatter diameter and how they correlate with glomerular sclerosis in IFTA. And then ideally, at the end of it all, we'll be able to come up with a model using ultrasound parameters that can predict the presence and the grade of IFTA as determined and proven by biopsy, biopsy grading. We're looking at 3 different groups for evaluation. Of course, a small development cohort just to refine the imaging protocol and image acquisition parameters using adult volunteers. We'd like to use adult living donors as controls here, given that they receive extensive workup, and that there's no history of chronic kidney disease, and hypertension, and diabetes mellitus in these patients. A sample size of 20 is a good comparison here. And then our interventional group are individuals who receive transplant and, of course, receive all-cause biopsy. Within 1 month of their biopsy, essentially ignoring the indication as to why they receive biopsy, we'll essentially have them come in and we could be able to look at their more chronic lesions as graded on biopsy. Doing a sample size comparison against that small-bodied literature, while difficult, does point us in the direction that we need about 40 total per grade to really answer our question here. Our exclusion criteria is pretty standard, but what I will point out is this cardiopulmonary disease component. That is largely so that we can have individuals perform breath holds with up to 10 to 15 seconds. And then, of course, anything found abnormal on our ultrasound of the kidney is an exclusion criteria. And then, as I mentioned, these are the specific parameters we want to be pulling out. We want to leverage the body of literature already done for volume and renal length, as we know that there's likely going to be a moderate correlation there. We want to evaluate our form of elastography for stiffness, and then the more perhaps experimental parameters on this backscatter coefficient or the glomerular size we'll also pull out. The primary objectives here are going to be the Banff scores for CICT as well as IFTA, and proposing our hypotheticals there. So what does this all mean, though? If we say we succeeded, say I succeeded in running this trial and demonstrated that this is the world's greatest thing, which hopefully it will be. What does it all mean? Well, going back to our problem, we now have a way to, say, assess for the load of fibrosis immediately within our patients. And we can track that over time, whether again, be it for disease progression or treatment response. We can also potentially triage the need for biopsy earlier and earlier on and avoid an unnecessary biopsy and improve our clinical decision making right in perhaps our own offices. From a clinical trials or clinical studies perspective, we now have a way to say stratify our patients even further and look at these subgroups and not treat all individuals with a transplant the same, but really look at them in terms of the level of fibrosis that their transplant may have or the quality of their transplants. One can envision them in the future, once everyone, say, has a POCUS machine in their office, that we can do this all in the office, that instead of having to wait and request a biopsy and try and guess around what's going on with the fibrotic load, we might be able to measure that in real time for ourselves. Of course, we're not a one-trick pony. We're considering how to evaluate this for the CKD population, moving upstream along that disease state to individuals as they progress towards end-stage kidney disease. We also want to look at the pediatric transplant recipient population as well, as these individuals do receive protocol biopsies, although they are smaller numbers overall. And then even away from fibrosis itself and more upstream from fibrosis, I briefly mentioned some inflammation pathways that lead to fibrosis. And if we can detect the presence of hypercellularity or perhaps the types of inflammation, I differentiate that from other issues, say rejection or infections. That might be powerful. That'd be quite interesting to see, and we perhaps could prevent fibrosis from accruing and be more agile in our responses. I'll end there with a thank you to my supervisors, Rob and Chris, as well as the committee and the group of students I'm fortunate enough to work with, as well as all our collaborators and every individual that's provided their thoughts and expertise into some of the study designs and helping me be essentially the best I can with the work I'm doing here. And I will end there and take any questions.
Thanks, Rohit. Certainly very stimulating thoughts, and I guess one of the interesting I'm going to look in the Q&A, see if anyone's got any questions, so we can open it up for questions. So I think the important thing, and I know that you know this, we need biopsies for other kinds of diagnosis. I think the notion of following up people and correlating, the change in GFR to fibrosis score so that you know that you've got a scarring kidney or a non-scarring kidney, and the way that we could follow people, for example, both clinically or in studies, is pretty exciting. I wouldn't want anyone to think that we don't need to do biopsies for diagnostic purposes, but I think for follow-up and for understanding what's going on, I think it would be quite interesting. Have you thought about looking at the donor kidneys by this ultrasound methodology prior to putting it into the recipient, and then looking at that concordance or discordance, because at the very beginning you should have very little fibrosis as you would in the donor kidneys, and would that make some sense as well for proof of concept? Or
yeah, it's an excellent question. It'd be a great proof of concept as well. It's very aligned.
They also get implant biopsies, right?
Yeah.
Even if they're living.
Yeah, exactly. Darren Ewan's work is very well tuned for that as well, for that ex vivo assessment of the donor quality. We could do something similar. The potential issues are that, say, our elastography or stiffness measurements, those are confounded by blood pressure. And so having an out-of-the-box, not inhuman assessment, there may be some confounders. That said, there are some ways around that in having a controlled environment. One can imagine perfusing the kidney and controlling the pressure there. So it's a rich area of research as well, say.
Great. Thank you. There's a question, if a nephrologist does not have any experience with POCUS, how much training would be required to perform your proposed assessment to determine fibrosis?
Yes,
See, they've already adopted it. See, Rohit, they've already adopted it. They're doing it.
I like it. I don't have a concrete answer for you. What I will say from multiple perspectives that here in BC, the ultrasound working group supported by the RCCPC is trying to advocate for more training and more accessible training for everyone. As far as how much time you may need to be, we'll say POCUS literate or POCUS competent, I don't know that just yet. Right now, they're staying in the fields of a fellowship requirements, but we could envision obviously more incremental and more longitudinal training. And then I'll also comment that from the technology side, particularly with Rob's work and Rob's group, is that we're looking at how to simplify ultrasound for everyone so that someone with minimal training could perhaps use it in select cases and select applications. Of course, all this in mind is the first and foremost priority is patient safety, and how can we do these in a safe and an appropriate way. So,
another question. Thank you for the excellent talk. Ultrasound can be helpful in extreme renal damage and decision for any intervention, but still biopsy is the gold standard for disease recurrence because of the degree of rejection, et cetera. I think you would agree with that, right?
yes, yeah.
I think, yeah, this is a tool that helps to assess and help interpret, if you will, GFR in a context and look for progression of disease. I think that'll be pretty evident. I'm just double checking the Q&A. Any other comments? Especially I noticed in the participant group that there are some of our transplant colleagues are there from around the province. Oh, there's another question. Is there any use in borrowing the FibroScan from our hepatology colleagues? So I think it's a good question because people will ask.
Yeah, so FibroScan has been briefly looked at. It has its limitations. It can't go quite as deep, say if we wanted to explore the far side of the transplanted kidney. It is pretty much a point-based measurement or a very small ratio of interest. And so if you're confident you can sample exactly from where you biopsy, perhaps, but the literature that I've seen thus far has been not compelling on the use of FibroScan for the kidney, given just how difficult it is and how varied it is, its differences from the liver. But by all means, I think I encourage anyone to start considering how stiffness and how fibrosis might be characterized in other ways. So.
Great, thank you. And I guess there's another question, more of a comment, but perhaps you can expand on whether or not you think this technology might be useful as a rule-out test. So if there are no findings of inflammation or fibrosis, would this be reassuring, especially if combined with other non-invasive biomarkers like urinary chemokines, cell-free DNA testing, et cetera? So like an all-in, quote, non-invasive methodology, like as part of a package.
Yes, yeah, so by no means do I think that we should only be using ultrasound or its variants or say some of the technology I've proposed here. It's all in conjunction with one another. I think this has excellent potential for a rule out, characterizing and knowing what a normal kidney looks like, and using that in combination with, say, more specific parameters for inflammation and rejection. So I think that's a great idea, and yeah.
Managing of the Q&A. So I guess as an MD PhD, like what do you, not lots of people do one or the other, they do them sequentially. And so maybe just to take a step back, can you tell us how you're finding this and what you think is different about this, this approach to going through medicine? Like what do you,
big question.
A little question for a Friday morning.
Yeah. Having done 2 years of preclinical training, so not my clerkship, I I think I was able to go through that experience asking a lot more questions about why we do certain things, and rather than accepting things as they are earlier on, right? I think many of us will get to that stage in our training and start to lean into the art of medicine rather than purely rely on the science and the guidelines. But I think it enabled me to say, really, is this the best we can do, or how can we simplify this for a patient, and really kind of align that. My PhD is quite significantly informed by my experiences in medicine, and of course the collaborations that I've been able to build from that and the network there. And we'll see, quite frankly, how well and refined I can become, because I don't want to be doing research questions for the sake of research. I think the medicine and the collaborations from my supporters, including Dr. Guan specifically, have been always pushing it back to the clinical relevance for our patients. So it's been a fun perspective on research, to say the least.
Yeah, no, I remember one of the things about, the half-life of medical knowledge is about 3 years. So learn how to learn. So I think that that's something that probably you're living, which I think is really great and a great example for all of us. I know that, or I thought that Chris and Rob were on earlier. I just wanted to see if they had any comments. You can unmute yourselves if you want to make any comments. Chris or Rob. They're not unmuting themselves. Well, there's no more questions that I can see. I want to thank you both for your curiosity, as well as a really outstanding presentation, laying out for us things that we know in a way that we perhaps haven't looked at them before. A fantastic description of the of ultrasound and the new technologies and the various ways that we can think about using old tools for new ways and evolving tools for new questions. So thank you again very, very much. And thanks to the whole audience for listening, and stay tuned, because there'll be a nice little POCUS machine near you soon with Rohit's methodology of helping to appreciate fibrosis in a new and different way. So thank you.
Wonderful. Thank you all. Thank you all for listening.
Thanks.